Thanks.
Sure.
Good afternoon to those of you joining from Europe, Africa and Middle East, and a good evening to those of you joining from South Asia and beyond. A very warm welcome from myself, Vijay and Arthrex. Before we begin, I want to take this opportunity to extend my sincere gratitude to our faculty and expert panel who have spent a significant amount of time pulling together clinical cases for today's discussion and debate. Joining us from vibrant and glorious India, we have Dr. Nagraj Shetty from Mumbai, and from Chennai, Dr. Clement Joseph and Dr. Vijay Reddy. Also joining us from victorious England, we have Dr. Mark Frame from Southampton. And moderating today's session is Dr. Mark Ferguson, and today's panel contribute over 100 years of orthopaedic experience. So there is no doubt that today's webinar is going to be extremely engaging. And before I pass over to Dr. Mark Ferguson, I'd like to cover a couple of house rules. To begin with, it is my legal obligation to inform you that this webinar is being recorded and subsequently will be broadcasted on social media platforms. Now, for those of you joining us via MS Teams, we kindly ask you to remain on mute with your cameras switched off. And this really is to help us achieve a calm and stable environment so that we can all enjoy the information that is being shared. Now, throughout today's webinar, you will have the opportunity to put forward your questions via the chat feature icon, which is highlighted here by the red arrow. And we will also be introducing polls, which will flash up on your screens. Mark and I will make an announcement when these are live and active. We strongly encourage you to participate so that we can make this session informative and interactive. That's it from me. So Mark, over to you.
Thanks, Fish, for a very kind introduction and for bringing age into this faculty. It really is a great pleasure to be with you all, and thank you to the faculty for their time and to also everybody out there who's joined us today. Just before we start off with Mr. Frame's first case, one thing that struck me is that I suppose possibly 10 years ago, you wouldn't have an educational session like this purely dedicated to meniscal preservation. So I'd really like to just sort of maybe whip around the faculty and get their opinions and all their collective experience. What was the driver now for meniscal preservation in their practice? Is it more outcomes? Is it more technology? Is it tools that we're getting? Dr. Reddy, you want to kick it off and maybe help us try and understand, and our audience understand, why we're trying to preserve the meniscus and what's influenced you?
Yeah, Dr. Mark, probably understanding of this meniscal tears has come, in this last 10 years, I think we have come a long way. And probably instrumentation, probably 10 years back, we didn't had great instrumentation. What you see today, any Scorpion or a Zone Navigator, or for that matter, all inside fiber stretcher. All these things were not there 10 years back. So probably understanding of this meniscal tears and the technology all put together, I think has changed the way we look at meniscal tears.
Dr. Joseph, what's your experience? Maybe on mute?
Yeah, may need to unmute there, Dr. Joseph.
Yeah. The one thing is we are not sure about outcomes, and more data we have been seeing. We have been much more confident in offering these repair techniques to our patients. And the number two would be the technology. If you go back by 15 years, we had inside-out repair techniques and outside-in. And all inside techniques used to be arrows, and they are not suture-based implants. So one major advantage technologically was the availability of suture-based all-inside repair, which was initially an implant-based suture repair. So now with all the techniques available for us, and also we have become more confident after going through data by people who are preserving meniscus. We are much more confident in offering the solutions of meniscus preservation. I think it's a fact both outcomes oriented as well as technology based.
Yeah, no, it's interesting. Dr. Shetty, anything you can add to that?
I think what I can add is that as far as meniscus preservation is concerned, we have come a full circle. So if you see the data from Steve Arnoxy, from Frank Noyes, so late 80s, early 90s, I think we very well knew the vascularity, we very well knew about the inside-out techniques. So I think it was always about convincing ourselves that we need to preserve more of these. The identification of tear patterns like the ram tears, the root tears, I think has been the game changer. Because these are the essential meniscal lesions which I have felt is responsible. For example, if you miss a ramp lesion, you see them that they go for failure of their ACLs. You see that these ramp lesions become bucket handle tears later. So the understanding of the meniscal anatomy was old, but the identification of newer tear patterns, obviously the data coming in, all the points which was mentioned, and the essential lesions that have come in. I think all these has added to the present increase in the awareness and the repair techniques.
True. Mr. Frame, anything different from that's coming out of the UK which has influenced you? Might be on mute.
Sorry about that. So I think it's a wider education beyond orthopedics in the UK. You know, somebody attending the emergency department that ends up with a sore, swollen knee isn't sent away just being told that they've got a sprain and to kind of walk it off. We're now got a greater appreciation that these are significant, and the access to things like MRI and the diagnosis of the injuries with really high quality MRI imaging and an appropriate pathway through to skilled surgeons who have an understanding of what and how important a meniscal tear is. You know, the data, I think, is absolutely key. We can see from studies and things that, you know, removing a meniscus increases your contact pressure by 235%. And we know that there's evidence that and losing your meniscus is almost inevitable that you're going to end up with early osteoarthritis. So it's now no longer a question of people thinking things, it's fact. And now that we've all accepted that your meniscus is important and has significant consequences if not fixed, then it becomes a clearer pathway for people to actually go and address that. And like you guys have said already, the technology makes it easier. So, you know, before people were scared of having to take needles out the back of somebody's knee and protect the neurovascular bundle, and it was something that was beyond most people, to now having something really simple that's 2 clicks of a button with a fiber stitch, for instance, just makes it accessible for everybody to actually do. So I think it's a combination of everything.
Yeah, great points there. And I think also what we forget sometimes is it's not just the consequence of degeneration or that compartment. I think we're seeing more and more good, strong evidence of long-term data showing the importance of repaired meniscus and the stability it provides in reduction of ACL re-tear. Well, let's get on to your first case, which is going to be done by Mr. Frame. You want to take us away?
Yeah. So my practice is very much mixed. So I see adults and pediatric patients, and even more so, you know, pediatric patients are an ideal set of circumstances for meniscal preservation and repair. Not only do they have the rest of their life in front of them and a knee that needs that meniscus long term, but we've also got the advantage of the healing potential of somebody who's, you know, 12, 13, 14, 15. And patients are now engaging in activities that put them at risk, much more so than we did in the past. So I've kind of focused on a younger patient. So it's a 15-year-old patient playing football, really typical, jumping for the ball. And this reflects often the way that injuries happen to patients' knees in sport, is that they have their awareness and their proprioception, and they know that landing, for instance, on two legs is really important, and they survey the landing territory before somebody lands. But it's when somebody then interacts with them before they have that opportunity to land that pushes them off, changes the position of their foot. And this patient felt a twist, and they'll often give you a very classic history of feeling a pop, feeling something go, something's happened. They're very aware that there's a significant injury there, and they'll tell you that. Immediate pain and swelling, unable to weight bear on it, unable to play on and continue with the match, which is one of the questions that I always ask. You know, if somebody's had an injury and they've actually played the rest of the match, there's a good chance they're probably okay. If they've absolutely gone off, then you know it's something significant. So focusing on the examination, this is all stuff that we all know, but they turn up with a very tense, swollen knee, indicating that they've had an immediate swelling within their knee, which tends to hint that they're bleeding within the knee. Very difficult to examine due to pain the majority of the time. If you see somebody very acutely, there's almost nothing you can really get from that examination of their leg. I think it's really important to start simply and make sure that we don't get carried away with the availability of some imaging in some places. An X-ray is really important, particularly in the acute stage. You want to look to see that there's no fractures associated with this, that you've not got a lipohemarthrosis. So that fluid level that you'll see on an X-ray, that's a bit like the olive oil and vinegar that separates, so that any fat that's there is clearly come from a fracture within the bone or an avulsion of something within the joint. The A&E doctors looking at this patient couldn't really examine it properly, said that the ligaments are grossly intact, given advice that it's just a sprain, up you get, rest, ice, elevation, discharged with crutches. And, I don't know what it's like in everybody else's country, but at the moment in the UK, it's not ideal. And often the time frame between being seen in an emergency department and potentially coming back to a fracture clinic or seeing a specialist can be weeks. So, those weeks are really, really vital. So if we go on to the next one. So what happens? The pain settles. The patient tends to get better relatively quickly, particularly pediatric patients. They don't have an awareness or care. They just want to get back to playing football, being back at school, doing things with their friends. They're able to weight bear. Their range of motion is better, but it's not quite symmetrical. And again, particularly with pediatric patients, this can be quite easily hidden because children tend to be much more flexible anyway. Often they'll have quite a significant degree of hyperextension. So if you lose your hyperextension, it may well look as if you're out to full extension, but unless you compare it with the other side, it's difficult to tell. This is a really good sign. You can see that if your knee is not quite out to extension and you've got to engage your quads in order to stand still, you can't lock your knee out completely. That's a really good sign. So that kind of quad activation sign is a nice one just to kind of eyeball as the patient standing up in your clinic. Advised by their team coach, there's often somebody that feels that they're very informed about what's going on, but maybe doesn't have the medical knowledge to back that up. But instead of asking them to go and see their doctor, is told to go and see the physio, seen with physio for 3 weeks or so. And the mum was really concerned in this circumstance because they just feel that he wasn't getting back to what he should be doing. So eventually came and independently took the initiative to see orthopedics. Making the diagnosis, from my perspective, an MRI scan is the gold standard, and a high Tesla magnet MRI scan, very detailed. We've got the privilege of being able to get. It shows not just the thing that you're suspecting, but just the collateral damage that's often associated with that. It allows for planning of your surgery. What are you going to need? You think they've maybe got a meniscal tear, but are you anticipating that they've got a root tear, for instance? Have you got that on the shelf? Are these things available for you? So it's understanding what you might need. And again, more focused consent and really being able to inform the patients of what their expectations are after this. I think going in very open-ended and saying, it could be a scope, it could be a meniscal repair, it could be a resection, it might be a root repair, you might have a brace, you might not have a brace. that I don't think is particularly helpful. A lot of the patient's recovery comes from a mental understanding of an expectation of what's happening next. So to be able to say to them, we're pretty sure you've got a root injury. This is going to mean that we do a bony tunnel. That means that you're potentially going to be in a brace. This is how long it's going to take to get better. Patients do much better knowing the timeline and knowing where they're going to go with their recovery, rather than it being a surprise at the other end, and often feeling disappointed that they've had something more significant done, which I then think has a very negative impact on their recovery. So the MRI in this circumstance shows us a displaced bucket handle tear of the lateral meniscus. No other pathology was really noted. And you can see on the MRI imaging here, the one on the left-hand side, it looks as if they've got a really big anterior horn, but you can see that white line in between. So that's the anterior horn there. And the other bit's the displaced posterior horn of the meniscus. So it's a bucket handle tear. And at the back, you've got that empty space. And again, if you point to on the right one, again, you can see that kind of double stacked view of the anterior and posterior horn on top of each other. So I always find these T2 fat saturated scans the most useful for looking at things. So other possible options, again, it depends where you are. I had an interesting case of a patient who was 30 weeks pregnant, who had a bucket handle tear with a knee that was locked. And the possibility of us, or the safety of us being able to give her a general anesthetic, given the complications that she'd had in her pregnancy, suddenly became too much. She was very fearful. They didn't really want to do that, but equally leaving somebody for 3-4 weeks with a locked knee, and then they have a newborn baby and we don't know what's happening next, became really, really difficult. So the option of a local anesthetic nanoscope was fantastic. So if you don't know, it's a really small arthroscope. It's only 1.8 millimeters across. It's possible to do it in an office, to do it rather than in a theatre environment. And it gave us the ability, not necessarily to repair, because that's maybe a step too far under local anesthetic, but it gave us the possibility to be able to reduce the meniscus. So at least it was in the right place. At least it gave the patient her mobility and actually reduced the risk of her having a DVT by not being mobile whilst being very, very pregnant. So this sort of technology is incredible and giving us options that we never had before. So that was just a little aside of a situation. So I thought a question at this point would be great. And what would you do to manage this 15-year-old patient with a displaced bucket handle tear of their meniscus? And what I want people to think about is, in the situation of a standard district general hospital, for instance, or the general orthopaedic surgeon, and there isn't necessarily a specialist, or you don't have the skills to do a nanoscope or use Zone Navigator and deal with a root repair, etc. So what would you guys do? So I'll leave it up to the poll now. Would you just try and manipulate and try and reduce the bucket handle tear, do an arthroscopy and just take the meniscectomy out, take the meniscus out, do a repair and an arthroscopy, or would you just relocate it and refer it on to somebody that can repair it? So it'd be interesting to see what everybody thinks.
No, it's going to be interesting to see what everybody says there. And as I said, everybody has different circumstances, and not everything's right or wrong. Just to go back to your one slides exactly on the nanoscope, what would be your indications for using a nanoscope?
So that sort of circumstance, I think, is good if you feel that there's going to be no access to theatre for whatever reason, that actually doing something under local anaesthetic, or the patient isn't well enough immediately to have that done. Where I've been using it a lot more is not in the office local anaesthetic environment, but in the paediatric setting. I'm seeing patients that are 9, 10, 11 with ACL injuries, with meniscal injuries, and given just the size of these patients, putting a standard scope that's nearly 6.5 millimeters across into their knee and trying to get to the posterior horn, for instance, or into the recess at the back of the knee is incredibly difficult. And so being able to take that 6 millimeter scope, and instead of using that, you've got a 2 millimeter scope, changes things. I've got a video that's online showing an ACL repair, an ACL reconstruction rather, using nanoscope as your main scope, and it's good enough to be your standard scope in a pediatric setting. It's
good tip.
It's just as good.
Vish, do we have any results out there yet on the poll?
Yeah, indeed, Mark. So yeah, very interesting to see. But it's 77% are saying urgent arthroscopy and meniscal repair, and 22% are saying attempt closed manipulation to reduce the bucket handle tear.
Yeah.
And nobody selected any of the other options?
No, absolutely not.
Okay. So I think, like you said, there's no one way of skinning a cat. There's lots of different ways of doing things, and it depends on your skills. It depends on the environment that you're doing this in, and it depends on what kit you've got in front of you. So ultimately, the saving of the meniscus is the main goal. Having the skills to do it are super important. I think your first chance is the best chance. So you need to do it well the first time. And if you don't have the skills, send it to somebody that does. The worst thing that you can do is to do an operation poorly that's not going to work. So I think if you feel that you don't have the skills or you don't have the kit that's available to you, I would rather have a meniscus that's remained displaced for another day or another 48 hours, and then it goes somewhere that you can actually repair and fix it, rather than somebody having a go. I think if it's going to be extended period of time, then that option of going in and relocating it, so at least you don't end up with that plastic deformation, you don't have the ongoing damage to the meniscus or the articular cartilage, and it buys you some time for it to be repaired appropriately. And that goes with the reduction. I'm not sure that I've ever really successfully managed to reduce a meniscus closed. I'm not sure that I would necessarily subject a patient to an anesthetic without the option of being able to at least do an arthroscopic reduction. My concern about trying to do it closed is that even when you're doing it with a scope, it can be difficult to reduce the meniscus, and it needs that forward force to actually push the meniscus into that posterior recess. And my worry would be trying to do it closed is that you could actually do more harm to the meniscus than with it arthroscopically. So I think out of all of those, the option one is probably one that I would shy away from, unless your next step is to do it arthroscopically. So what did I do? So we identified that it was a very significant large red-on-red tear. So that's at the very posterior edge at the junction between the lining of the joint and the meniscus. And we identified that preoperatively from the MRI scan. So we made sure we had all of the tools. So you're better to have more than you need than not enough. So, I would never, and one term that always scares me in orthopedics is when you hear people say, we got away with it. There should be no circumstance that you get away with anything. You should be doing the right thing and having everything and every tool available to you so that you can do the right thing and not get away with it. There's no corners to cut. So the one that everybody's probably most familiar with, or the technique that people are most familiar with, is the all-inside fiber stitch. Zone Navigator is one of these things that you may not have seen, or you've seen but never used, but it's possibly one of the second best things. It is incredible. It's not complicated. It looks quite complicated. It really, really isn't. And what's amazing is that actually you can fix a meniscus, the anterior horn, and through an arthroscopic portal, and actually direct needles right towards yourself. It's that flexible with the nitinol needles and sutures, and it's a very, very, very secure fixation. Always have an outside-in needle set. It's cheap and actually will get you out of trouble. It's a fantastic thing, and it's an easy thing to learn. It's something that's relatively old-fashioned, and I feel as if it's something that trainees don't learn about or don't use, but it's always something that you should have. You don't even need really advanced pieces of technology. A couple of Venflons is enough for you to be able to carry that out, even if you don't have a proper set. So just understanding that skill and technique is really important. Have a shaver. We all have standard shavers. Normally, they're quite aggressive shavers for what we use. If you've never seen it, the torpedo shaver from Arthrex is fantastic. I think it was originally designed for ACL repair, but it's a very closed mouth. There's a very small opening on it, and it's all very smooth. There's no teeth to catch anything or do any harm to the articular cartilage. But through that opening, it's relatively aggressive. And it just gives us that ability to be able to freshen up that interface of the meniscus to allow the healing potential to take place. The meniscal scorpion, understanding how to use that is very important as well, and relatively simple and straightforward, but it's an understanding of how to use it. And again, the nanoscope, if it's there and you have access to it, even as an accessory camera, even if you're not going to use it as your primary camera, can be very useful to get to specific areas. So these are images from that scenario. I've kind of annotated them as well. You can see the femoral condyle at the top left, and then you see the displaced meniscus. So that's the view that you get when you first sweep into the lateral compartment. You've got the ACL. You can't really see anything at all because that meniscus is sitting exactly where you need to be. And the other view, again, is moving further across, and you can see the femur, the posterior horn, and you can see the size of that meniscus and how significant that tear is. So if we go to the next slide, and that's us, you kind of use the probe and on a figure of 4, opening the knee up to give yourself as much access as possible and pushing that back. And we were very lucky in this scenario, I think because they're 15 and it was relatively fresh, that it really sprung back and wanted to go back to where it was. And I know that there's a discussion later about the sort of irreducible meniscal tears, but that's your kind of worst nightmare, is the plastic deformed meniscus that just doesn't want to sit where it should be. So we repaired it with the fiber stitch, freshened up that interface. You can needle it, you can use a microfracture awl, there's diamond rasps, there's shavers, there's lots of things, as long as you get that interface so that it's not full of fibrin and it's not going to heal together. Identify I use an initial suture, so find that spot that's going to reduce everything really nicely for you and give you a really stable first reduction, even if that's temporary. I think that's a really important suture, because if you're fighting constantly with poor tissue and everything's sliding around, you'll end up doing more harm than good. So I use a technique that I remember seeing when I went to do a fellowship with David de Jour, which is used almost like a horseshoe technique or like a staple. So instead of going through that macerated tissue, you go above and below the meniscus completely and just use it to pin the meniscus into the corner. And often that's a fantastic compressive stitch that you want that compression at the interface. It's a bit like fixing a fracture, and it prevents it cheese wiring through. And like I said, even if that's temporary, you can cut that at the end once you've had stability of your meniscus to help you fix it. Really important to understand the danger zones. You know, the posterior horn from the same-sided portal, as shown in studies, that's the most at risk you're going to get with regards to the neurovascular bundle. So fixing the lateral meniscus from a lateral portal where you've got direct access with a curved needle for the posterior horn, you've got to be very aware that you're not heading into that neurovascular bundle. The fiber stitch, for instance, has a depth gauge. Make sure that you adjust that appropriately for where you're going. And doing pediatric patients, remember that they're smaller, and just make sure you're pushing less needle into the back and be very controlled with what you're doing. And that's where the nice sharp needles of the fiber stitch are helpful, that it gives you that control and feel. Plan your suture positioning. Use your probe to pretend where you're going to go. The worst thing you can do is put it where it's easy, and then you're kind of stuck as to where you go to spread them out appropriately. And if you can't get to where you need to be, don't struggle. If you can't get there, you're definitely not going to get there once you've got your needle in. So make sure that you can almost practice that you can get exactly where you need to go before you do it. And if you can't, make a new portal. Doesn't matter. You need to make a new portal. It's rather an extra hole, and you fix the meniscus properly than trying to struggle through holes that are not correct. Again, middle and anterior horn, that's where you want to use the zone navigator or the outside-in needles. Nanoscope for small knees, as we've kind of reiterated. This is a video of the meniscus being fixed with fiber stitch. Now, this isn't the one that we presented before, so it's not the lateral meniscus, but this is a medial meniscus, but this is an example of the fiber stitch. So you can see how extensive that bucket handle tear is and how unstable it is. So we used the shaver. There's the fiber stitch. You can see the all suture fixation device that gathers up and forms a little knot that secures. going through the meniscus, and then you can see it kind of then pierce the capsule in the second bit. There you go. And then deploy it. And I think I'm using the horseshoe technique for this because it's initially very, very unstable. So we've gone above the meniscus itself completely, and then we're going underneath the meniscus. Recently did some testing with the fiber stitch, and it's very, very important. You see that loop that's there, that you make sure your needle doesn't go through that loop because it can tangle things up and stop the mechanism working. So, you know, making sure you've got good visualization is important. Pulling that first one gathers everything down and just needs to be snug. And then you pull the second loop and that snugs down, and you can see the degree of tension and security. That's not going to go through that macerated meniscus. If you look carefully, we've taken a very small bite out just at the apex of that, just so it doesn't fold up the bottom edge of the meniscus when it's and you see the second one, mattress. So again, mattress technique, you can see the suture anchor gathered up in the tip of the needle. And again, that feel you can see going through the meniscus, then going through the capsule in two distinct hops. Deploy the first one. And then coming through. And again, making sure that you don't come through the sutures that are there, so you end up locking it. And then again, and you see it deployed, and then we tension it, and you can see the compression that you get with the fiber stitch, gathering the meniscus into that interface. And then the second loop going in. And that's the disposable cutter there. So we did a few more in the posterior horn of that one. But you can see the fantastic fixation that gives you.
Yeah, that's fantastic. It made it look very, very simple. Great technique there. Well, the fiber stitch. I just love to hear what the other faculty thinks of the horseshoe technique. I know that it's called the sort of circumferential stitch, or the Americans call it a barrel stitch. Dr. Reddy, do you use that stitch quite often? I see it, more and more videos nowadays.
Yeah, Dr. Mark. We do use fiber stitch a lot, and we do use this type of fixation too for this type of bucket handle tears.
Yeah, I think it is very helpful, especially more so, especially in those young people with. Yeah,
the amount of circumferential compression happens with this type of, the implant is great, really great.
Okay.
Well, I think just very quickly, I think it's super important, particularly in the lateral meniscus, because ultimately what defunctions the lateral meniscus is that loss of kind of hoop stress within it. And you can see that when you have a radial, for instance, that you get that lateral displacement of the meniscus, and even if it's there, it's not functioning. So I think, that first bite of really kind of putting the tension back into the meniscus is super important.
Yeah, very good point. Dr. Shetty, are you ready to tell us about your first case? This is an interesting one.
Yes, I'm ready. And at the outset, I'd like to thank Arthrex, Vishal, and Mr. Mark Ferguson for this opportunity. My case presentation here is of a 55-year-old homemaker, a typical case scenario. All of us have seen this, who presented with progressive but increasing left knee pain. The history was that she felt a pop from her knee when she was just standing up from the cross-leg position, which is a very common day-to-day habit in Indian women. Just about a month before she presented to me, she felt this pop, and since then, her pain has been worsening, and she came limping to my outpatient department. There has been no long past history of her pain, and this history is important because that tells me that this is not a degenerative knee that is presenting to me. She has recently decompensated. Her pain increases on loading activities. So whether she stands or whether she tries to climb upstairs, she experiences increase in the pain. Once I know the history, once I know that this is a acute decompensating episode, the next thing I want to see is that her alignment is fine, because I want to make sure that this is not a case of malalignment. And I also like to see her gait pattern, whether she's got any thrust pattern. So typically these patients might have a varus malalignment. This lady does appear to be in slight neutral to varus. So we need to exactly quantify whether this is a malalignment, for which we get a scanogram. So unless there is a scanogram, I do not proceed with the other investigations. So the mechanical axis being drawn from the center of the hip to the ankle. Just a few points that I'd like to add here. A few millimeters of about 10 to 15 millimeters of mechanical axis deviation, meaning up to the downslope of the medial tibial spine, especially if it is constitutional, meaning if it's symmetrical, is okay with me. We would consider it to be a constitutional varus. Anything more than that, we would be more careful in calculating the angles, the medial proximal tibial angle and the lateral distal femoral angle. And if she's anything more than 4 to 5 degree varus, I would then consider her for a malalignment surgery primarily, and then look at the soft tissue problem. With this, we'll go to the next investigation that we got it done was the MRI. Now, typical combination of MRI findings which we see on the axial image, as you can see on the right-hand side, you can see the medial meniscus root tear. The root is displaced away from its original attachment near the PCL. On the coronal images, you can see the line drawn shows that the meniscus is extruded. About 80% of the meniscus is beyond this line in the mid-coronal image. And this is actually the crux of the talk. All of us have heard a lot about root tears over the years. The crux of this talk is to talk about extrusion in the presence of a root tear. We will also add a few points about extrusion in the absence of a root tear. So here let's talk about the extrusion in the presence of a root tear. So you might have 3 case examples. This is a case example where there is a root tear. On the axial image, you can see the detachment. On the coronal image, you can see the meniscus here is not at all extruded. This is the classic meniscus where most of the meniscus is within the knee. The second case example would be of a patient with mild extrusion. So you need to quantify these in millimeters. There have been adequate number of studies, especially from the Mayo group by Aaron Critch, wherein they have said that anything more than 4 millimeters of extrusion on this mid-coronal image should warn you that unless you correct the extrusion along with the root tear, there is going to be increase in the contact, there is going to be reduction in the contact area and increase in the contact pressures. Therefore, that needs to be addressed. So this is an example of the moderate extrusion, about 3 to 4 millimeters of extrusion, and anything more than 4 millimeters is considered to be a significant amount of extrusion. So these are the 3 images which tell us that the extrusion is to be seen. In our patient, there was almost 4 to 4.2 millimeters of extrusion which was seen. So we have a patient who's in her mid-40s. She's having a neutral alignment. She's having a root tear. She's having meniscus extrusion almost more than 4 millimeters. So what are our options? So can we have the poll? Whether we want to do just an arthroscopic debridement and a root meniscectomy type of procedure to relieve her of her pain, like a palliative procedure. Whether we want to address her alignment, whether we want to do only a root repair, or whether we want to do something about the extrusion, what is called as a centralization procedure, or also we need to primarily address in the centralization the meniscotibial ligaments by repairing them.
Now, this is going to be an interesting one. I'd just like to hear from the rest of the faculty. Dr. Joseph, what are your indications here to go for realignment to high tibial osteotomy? We heard Dr. Shetty mention it was, 15 millimeters down the medial slope. Do you have any other criteria when you would use a high tibial osteotomy?
So in these patients, to add high tibial osteotomy, I will have a low threshold if the patient is less than 50 years, because even slight unloading of the medial compartment is going to help her in the long way. But patients typically who are above 55, probably I may not add a high tibial osteotomy. And from a skeletal planning point of view, if the axis deviation is more than 15 to 20 millimeter from the midline, probably I would consider adding a high steo to the root repair. And also presence of a varus thrust is a very clear indications for adding meniscus, high tibial osteotomy in my cases. So even if the varus is moderate to severe, and especially if the patient is young, in those kind of patients, the high TB osteotomy is going to give much more improvement in the function and also in protection of your root repair long term than doing a root repair alone. Probably in elderly patients, normal alignment with an injury, probably I would go for root repair alone. That's all, Mark.
Yeah, thank you. Thanks very much. Yeah, it is difficult. It's hard to really give everybody a good indication. I know Kogar talks about less than 30% of the mechanical axis. The Koreans usually say more than 3 degrees or anything like that. I'd say that's one of those criteria in combination with the root. I don't think we've really got enough evidence at this stage. Vish, do we have any results from our poll yet?
Yes, indeed, Mark. So 100% would actually go for a root repair, but of which 75% have actually said they would also do a meniscal tibia repair as well.
Okay, well, that's great. Let's get on to what Dr. Shetty did here.
So I went ahead with the meniscus root repair and centralization procedure was my plan. That's a medial compartment. We can see there is a wear pattern. I do the pie crusting initially to open up the joint space. So that's me doing the pie crusting because there are going to be bulky instruments that are coming in. That's the root avulsion type of tear. This is not a tear which is a radial tear near the root. There's only a flimsy tissue holding back the root. I clear out all the condyle fraying. I release some amount of the adhesions between the root and the capsule, which makes sure there is a low tension repair. So all the adhesions are released. I also create a transpatellar tendon portal, which helps me in suture management. I burr out the medial tibial spine to increase the biology for my root healing. I get a curved shaver blade and create a raw surface area because I want a good raw healing surface area. I use the knee scorpion to first pass a 0 number fiber wire and then shuttle a suture tape over the fiber wire and station them in the transpatellar tendon portal. I then get my dedicated root repair jig. So this is me placing them in the transpatellar tendon portal, dilating the medial portal to get the jig in. You need to come at the anatomical attachment of the root. Even a few millimeters of staying away from the anatomical root is shown to create a biomechanically poor repair. So that's the guide wire coming in, and then I create a slightly larger tunnel of about 5.5 to 6 millimeters. I also do not hesitate to do an eccentric reaming in order to get more and more anatomical. Curette out all the cartilaginous flakes with a curved kind of a curette to get a nice healing bed for my root. So that's the tunnel being created. I then get the passport cannula in the medial portal and use a passing ethylene loop to shuttle these tapes into the tunnel. So that's the first part of the procedure. That's the standard transtibial pull-out suture root repair. My assistant is now pulling on those tapes. I get a mid portal from which I get my hemostat dilated. Then I use the Bankart liberator to release the meniscotibial ligaments and all the adhesions there. This is the rasp from Arthrex, which is a very nice angle to clear out the adhesions in the meniscotibial gutter. All during this procedure, the assistant is pulling on those tape sutures. I also use an upbiting punch sometimes if I feel that there is still a lot of tension. I like to use all suture anchor kind of repairs here. Try to come as in the mid portion or in the posterior portion as possible of the medial border of the medial tibial plateau. This is another image of the anchor coming in.
Sorry. My apologies. Get back to where you were.
So we have placed the anchor, an all suture anchor, and then so that's the pie crusting video. So Mark, could you just pause it for a second? So what I want to show here is that you need to place the anchor right at the edge of the medial tibial plateau. You need to make sure that you are reducing the meniscus, you are centralizing the meniscus, and you are reducing the tension on your repair. So you want your tightening to go in such a way that the sutures are passed through the meniscocapsular junction anterior to your anchor. So your anchor goes as midline and posterior as possible, and the curved micro suture lasso is the ideal instrument to shuttle the sutures, which we will see in this video now. So Mark, could we go ahead? So just behind the anchor, the microsuture lasso penetrating at the meniscocapsular junction, the SD wire loop is being retrieved and the sutures are shuttled one by one. Both the sutures obviously will be shuttled in a mattress fashion. I sometimes place two anchors, so one anteriorly and one posteriorly. You will see that in the next part of the video. So that's the second all suture anchor that's coming in. So that's the angle, that's the assistant holding it in about 30-40 degree flexion, external rotation at the tibia and mild valgus. That's the anchor being placed from the mid portal. That's the first suture and this is the second suture. So it's a repetition of the steps. Retrieve the sutures in the passport cannula and the medial portal. Use your microsuture lasso. The assistant is always pulling on the tape sutures, especially when you're passing through the meniscus. This is the most important part of this procedure to make sure that you have a low tension repair. So that's the microsuture lasso again, sutures being shuttled in a mattress fashion. All of us who do shoulder surgery will find this quite easy because you need to now create a virtual cannula in the mid portal. So retrieve the sutures from the second anchor into the cannula once they're passed through. So that's being retrieved into the passport cannula. And then create a virtual cannula. So use your suture manipulator twice to make sure there is no soft tissue bridge. Pull on the root tapes and then tie your knot. And this makes sure that your meniscus is centralized and holding there. You can also now tie the second pair of sutures. You get a wonderful reduced meniscus and a low tension on your root repair. So that's the root repair being tied over a button. You can use a swivel lock or a post or a suture button or a suture disc, anything of your choice. And that's the final repair. We've been doing this since the early presentation by the Japanese group. And 2018 onwards, we have the follow-up of our patients. And we find that when selected appropriately, these patients do extremely well in terms of pain relief, in terms of the good outcomes. That's about the technique. This is the early follow-up of these patients. I put them on an offloading brace at 2 months, and they continue using that for about 7 to 8 months of duration to make sure that your root repair and your centralization is well protected. We do have some MRI images of our follow-up of our patients, which I think is the proof of the pudding. So this is the comparison of the pre-op on the left-hand side, where you can see the root tear. And on the right-hand side, you can see the post-op. This is about a 2.5-year follow-up of one of our initial patients of root repair with centralization. And you can see very good healing of this, at least some healing tissue in that area. The next image, please. On the coronal image, is very gratifying to see that the extruded meniscus is now well centralized and this is maintained. Yes, there are a lot of studies which say that the maintenance of this extrusion is an issue. It tends to remain extruded, but that's not always the case. If you select your patients appropriately, we see that they do remain reduced. Next image, please. And this is the coronal pre-op and the comparison post-op. So you can see the healthy cartilage in this lady who was about 45. We've been able to conserve her knee, and I would call this as a true knee preservation procedure. And the proof is in the pudding. So having the pudding. So you can see the images of the healing. This is the marathon runner actually who had an extruded meniscus. We did the same release and repair of his meniscus root, and the centralization was done. He's a very avid marathon runner. It's been very difficult to hold him from heavy loading activities. This is about 9 to 10 months post-op, full range of motion, complete relief of pain, and he's able to even do light jogging, etc. So I think we are now able to push the envelope in terms of meniscus preservation. If we have these tips in our kitty and have the appropriately selected patients, we can get good outcomes. My take-home message is that the first thing is you need to check the alignment. Unless you are very sure that the alignment is fine and osteotomy is not needed, only then you need to go for these procedures either in isolation. Otherwise, you can combine it with your osteotomy. Identify the appropriate images on MRI. We have discussed how to identify the extrusion. We have discussed how to quantify the extrusion. So anything more than 4 millimeters of extrusion, you need to think in terms of this centralization procedure. Because you do not want a high tension repair, it's going to fail. You do not want a non-anatomical tunnel. Laprade and group have clearly said that if you're off by even 2 to 3 millimeters, it's going to fail. Any extrusion more than 4 millimeters, there has been a recent publication by, again, from the Mayo group, that you will have a poor outcome if you leave them alone, and therefore you need to do the centralization procedure. Thank you.
Thanks, Dr. Shetty. Well, you made that really look easy for a complicated case. Really nice case there. A lot of people have sort of technical difficulties with root repair. I see a lot of the younger surgeons really struggling. Any tips and tricks how to get that access there at the back? And is there a long-term effect of doing a pie crusting, or anything else you can do to help that visualization?
I think you're absolutely right. Initially, when we started this, we did have difficulty in visualization. Pie crusting has been the most important trick in our kitty on the medial side for exposing this area. There has been absolutely no problem whatsoever in our cases. You just need to make sure that you use the pie crusting very judiciously. You open it only as much as you require for visualization. So I use a 18 gauge needle from my TOR set. I just ask my assistant to not give a heavy valgus force. So just small fenestrations. I do it on the tibial side. I do not do it at the level of the joint or at the femoral side. I do it at the tibial side. I try to target the posterior fibers. I use it like a tenotomy blade, the sharp edge of the needle as a tenotomy blade. So I stop when I realize that it is just open to my satisfaction. So these are my tricks for the pie crusting. Once I've visualized that area, once I can see the root very well, the second challenge is always in making sure that your guide wire comes exactly at the level of the root, at the original anatomy of the root. So I use these dedicated root repair jigs. Arthrex has got wonderful of these jigs which you can create. And you need to make sure that your assistant is holding the scope to visualize that area. You fix the point-to-point jig well. It doesn't slip out when you're drilling the tunnel. And if you feel that you're slightly off, you can do an eccentric reaming. So you can use a 4.5 reamer, hold it with a hemostat, get a 5.5 and then a 6 mm, and you can get more and more anatomical near the root area.
I think those are great tips. They really are. Great to see that your follow-up as well, which is okay. Be very interested to hear. Dr. Koga is just about to submit another paper here, where he's shown that there's actually an increase in the gap of the joint, the size of the joint gap on that side where he's centralized. Are you seeing that with your early follow-ups?
I'm very happy to share this with you. This was a case which just came into my outpatient department yesterday. Now she's in that 55 plus age group which Dr. Clement talked about, and I had done only a root repair in her about 3 years back. To be frank with you, she's showing patellofemoral arthritic changes, but to my surprise, on a plain X-ray, her joint space is still well maintained. So I think we are doing the right thing in terms of especially the root tears. I think if you identify them appropriately, they are not in their advanced stage of degeneration. I think the joint space is well maintained. Of course, you cannot give them a 10 to 15 year lifespan, but if they are in their early 50s, even 7-8 years of pain-free lifespan before they go for a knee replacement, I think it's totally worth it.
Thanks. Those are great things. Oh, the one that always makes so difficult with decision making. Dr. Reddy, solve this problem for us.
Thanks, Dr. Mark. So greetings from Chennai. At the outset, I would like to thank Dr. Mark Vishal for giving me this opportunity. So 20 years male, a professional athlete who plays cricket, came to me right knee pain following twisting injury while playing cricket. Had a difficulty in walking, standing, and pain in movements. So he presented to me after 10 days of his injury. Mark. So on examination, his BMI was 22. He had a normal gait, no effusion. Range of motion was 0 to 90 degrees. He had tenderness in the lateral aspect of his knee. McMurray was positive. Droyer's test was negative, and normal ligamentous examination. Traditionally, we do X-ray MR. The X-ray shows there is no significant fracture, and the MRI, as Mark said, is a gold standard for any meniscal tears. So we picked a radial tear in the lateral meniscus. So to come to a radial meniscus, we have a partial radial meniscal tear and a complete radial meniscal tear. Complete radial meniscal tear starts from the white to red and red zone. So, and also to understand this partial complete is very essential, in terms of a medial meniscus and a lateral meniscus, because the choice of treatment and choice of implantation, everything changes. So at this point of time, I would like to ask, so the radial meniscal tear treatment options for this particular patient. Number one is partial meniscectomy. Number two is a combination of inside out or outside in technique, or all inside, or a transtibial tunnel pull-out repair. So the options are 4.
There you go, Vish. Let us know what's happening. And also, have there been any questions been submitted from any of the people attending?
Yeah, thanks, Mark. So we just wait a few more seconds for the poll to come in. No questions as yet coming forward.
Yeah, to all of you out there, don't forget, you're just on the chat room. Just click at the top. You've got free advice here from, as Vish said, over 100 years of experience. Unfortunately,
105 to be precise, Mark.
Okay, yeah. I think it all comes from me. Dr. Reddy, we're going to obviously talk about repair here versus meniscectomy. Obviously those little ones on the sort of inner surface, we always do a little meniscectomy. Those ones that look bigger, we're going to try and repair. Now we know the importance of it. How do you make that distinction,
If it is a completely a wide zone, then definitely one can think about partial meniscectomy. But if it is the thing is going inside white, red, and red zone, then I think seriously we need to rethink ourselves to fix it, because all of us know that radial tears give rise to a loss of hoop stress and increased contact pressure. Like Mark said, the untreated radial tears are like undergoing a total meniscectomy, and as Mark said, these radial tears act as a total meniscectomy. Hence, there will be a rise of arthritis 235%. So one need to really think of fixing them if it's complete.
Yeah, I think there's enough biomechanical studies out there now to show that even if it's up to sort of 60% of the width of the meniscus, that alters the biomechanics fairly significantly. I think Betty showed that quite nicely. Vish, do we have any results?
Yes, Mark. So 75% would suggest that they would go with an all inside and an outside in technique, and then 25 would consider a ripstop repair with fiber stitch.
Oh, okay. Right.
So I think it's a complete lateral radial tear of the lateral meniscus. So we had a complete plan of doing an all inside technique because it's a lateral meniscus. Is the one second is very near to popliteus. So we had everything on table, but we thought initially we could able to get out with probably a knee scarpion by doing a side to side repair by giving a circumferential compression. So after anesthetizing the patient, we kept the patient in 90 degrees, hip in 90, knee in 90 degrees. And we had a standard 2-portal technique for a lateral meniscal radial tear. And here is the video showing the radial tear of the lateral meniscus in the junction of posterior and middle. So it is a complete radial tear type. So we thought we'll do a side-to-side repair by using a knee scarpion. Knee scarpion is very easy to use and low-profile curved. You can use with a single portal, so it's very efficient. And when we take up bites, we make sure that we don't take we little curve on left right so that it won't go and poke into the cartilage. It's a very versatile and also very small perfusions it takes, the scarpion. So we take side-to-side stitches, and we repeat the same type of bites about 3 to 4 times to get an anatomical reduction. So the circumferential compression and anatomic reduction is the key to get a proper fixation of this type of radial tears. So I do post repair of my meniscus. I do a marrow perfusion by doing a microfractures intercontinental area, so that it gives that fibrin clots, and definitely try to give some bone. That definitely makes meniscus to heal better. So I do a bone marrow perfusion. So coming to the conclusion, these radial tears, untreated, they act like a meniscectomies. Hence, there will be a high chance of arthritis. So treating this radial tears, complete tears, is very, very essential. We all need to remember the ABC of meniscal tear. A is anatomical reduction, B is biological preparation, and C is circumferential compression. We need to always think of all these three, and various treatment options are available for medial and lateral meniscus. Medial meniscus, there are different type of treatments are available. Lateral meniscus, definitely all inside is definitely a great choice, and the selection of the treatment depends on the lateral and medial meniscus. Thanks for your attention.
Thanks very much indeed. It really was a nice video that you showed there. Common question that we always get asked with these sort of things: do you change your rehab for radial tears?
That's a very nice question, Dr. Mark. I do put them into a non-weight bearing regimen for 4 to 6 weeks in a knee brace, and allow them 0 to 90 degrees at least for 6 weeks.
Okay, that's great. With isolated tears, we know that the sort of repair rate is not as good as those associated with ACL. So that marrow perfusion is great. In the UK, Mr. Frame, do you add anything else? Do you ever do some PRP, add any stem cells, anything fancy out, which we're missing out on?
At the moment, I don't. I think I've used some using the Arthrex blood spinning technique, and kind of as an additional kind of hope. I'm not sure that there's a huge amount of evidence to back that up. I think there's definitely something in it, and I think we just don't at this time really understand what kind of, whether it's PRP, whether it's fat cells, whether it's whatever it is. I think there is absolutely healing potential to be added with biologics, but it's really, there's a lot more to be done in trying to actually understand what's best for what thing, whether that's articular cartilage regeneration, whether that's helping meniscal tears heal. I think you've got to, I certainly work on the basis of evidence, and the concern is that you're either giving hope for something or you're potentially doing harm if you don't understand what it is that we're doing. So I like to have evidence and a reason for doing something. So at the moment I don't do a huge amount of it, but I have no doubt that in the future biologics are going to play a big part, particularly in meniscal healing, for sure.
Yeah, that's a good way of saying. There's some new evidence out there, some good randomized trials showing the repair rates of adding biologics as well as your marrow and platelets. It's all, I suppose, it's about cells, signal, and structure as well that you got there. Let's get on to Dr. Joseph, who's got some interesting meniscal lesions here for us.
Good evening, everyone, and thanks Arthrex team and Mark for this opportunity. So my case is a 22-year-old medical. She presented 3 months after the knee injury. It is surprising in our parts that even doctors like her in medical field, they choose to go for the traditional medicine, and so much of time was wasted when she presented to me. On examination, she had a positive anterior drawer and Lachman test. She was unable to extend the knee completely. Next slide, please. And this is a MRI, or the coronal sections show hardly negligible medial meniscus is seen here, but on the contrary, you can see medial meniscus lying in the intercondylar notch. So the diagnosis in this patient was an ACL tear along with a persistently locked bucket handle tear. And this was an irreducible bucket handle tear, as Dr. Mark Frame was referring. Can you show the video? Yeah, this is how it was presenting to me. And it was truncated, and it was very difficult to reduce it. It is coming back all the time. Next slide, please. So at this stage, we'd like to discuss the options. So these are the options. Would you do a meniscectomy, then go ahead with an ACL reconstruction? Would you do an open meniscus repair? Would you consider meniscus reduction and fixation techniques? Or would you remove the meniscus and do a staged meniscus transplantation later? We'll wait for the poll.
If this was an acute ACL and bucket handle, you know, the real ones just happened a few days ago, very swollen knees, tender, painful, patients unable to weight bear on it. What's your decision making there? You obviously want to reduce, as we know, we want to reduce that meniscus as quickly as possible, but do we want to do an ACL reconstruction in what we call a sort of angry knee? How do you manage that dilemma just while we're waiting for those poll results?
Very difficult for us to get an acute case. And if at all we get an acute injury like this, I would like to do both together and probably admit them, put them on anti-inflammatory medications, a lot of icing, and then I go ahead with an acute ACL repair and medial meniscus. I don't do staged procedure. And I explained to them there is a chance of knee becoming slightly stiffer, so I tend to be more aggressive with my rehabilitation and range of movement exercises. Usually we get away with this aggressive rehab program, even in acute combined procedures of ACL reconstruction and meniscus repair.
Yeah, that's a good way of looking at it. You know, I suppose the most important thing here is, you know, listen to the knee, see what the knee's telling you when you make those decisions. Vish, thoughts there?
Yeah, thanks, Mark. So interestingly, 25% would say a meniscectomy and an ACL reconstruction, which again I find very interesting, whereas 75% would consider a reduction and various fixation techniques.
Okay. You've got to convince us what we're doing here then.
Okay. So in this particular case, we anticipated problems because the meniscus was unreduced for a few months, and it was also irreducible. We were worried about the tissue quality because sometimes this meniscus become truncated and contracted. We won't be able to align with the periphery, and the meniscus tissue also become contracted and springy. And if the one thing which we are afraid in this scenario is you try to repair and then you find out that the first suture implant, whatever you're using, has reduced the meniscus but in a wrong position. So either you won't be getting a reduction anteriorly or posteriorly. So it's very important to have a proper reduction. The technique what we would like to consider in this case would be to have a good access to the medial compartment by means of MCL pie crusting. And I use reduction sutures. I prefer to use outside-in sutures. So once you use your implant-based or an all-inside sutures as a reduction technique, it cannot be revised easily. If you're, for example, if you're using a fiber stitch to reduce your implant, and if it happens to be malreduction, there is no way you're going to revise it unless you go inside and cut your sutures, which is going to make your life difficult. So my technique in these cases would be I use outside-in sutures as a reduction sutures, followed by inside-out the corner suture, which holds a reduction, and then I complete the repair with all inside suture-based implant systems. And sometimes I have considered, especially when there are a lot of anterior horn instability despite an extensive repair, we have added transosseous sutures, suture anchors anteriorly. Also, I have not hesitated to add an open meniscopexy with the tibial margin. So this is a video technique what we have done in this particular case. So once again, the meniscus tends to remain springy. We try to reduce it. And then there's a look at the periphery. It's 2 to 3 millimeter from the capsular margin. So it's an ideal theater meniscal periphery with shaver and rasp to create a healing response. So just approximate the meniscus to the periphery, and then pass some outside in sutures, one through the meniscus body and one above the meniscus. And I tend to use just 20 gauge spinal needle and pass Prolene sutures, take them both out through the same tract of soft tissue into the anteromedial portal, and then relay them with the number 0 fiber wire. Once again, reduce the meniscus, pass a posterior outside in suture, and take the Prolene sutures out in the same track and relay them with number 0 fiber wire. It's very important to add undersurface sutures also, because if you keep on doing sutures tend to become flipped upwards. So I'm adding an undersurface outside in sutures. Once again, number 0 fiber wires have been taken in, and this is the 4th outside in suture. Once again, an undersurface suture, Prolene sutures coming out, one through the capsule, one through the tissue. And so they are vertical matter sutures which are quite solid. And there's a 5th outside in suture coming anteriorly. Once again, similar steps are being repeated. So once I tackle the anterior reduction, anterior fixation, now I can go to the middle third and posterior third repair. Now you can see I'm putting traction on all the anterior sutures, and use an inside-out suture to reduce the posterior corner, and the posterior third meniscal tear with the help of Arthrex fiber suture. And from the time of my repair, we've been observing that the entire tissue is a little bit more anterior. So I hoped that with this suture, the meniscus posterior horn will be pushed back. So to some extent, we are able to push it back. So first fiber wire fiber stitch has been applied. So this is a second all inside suture being done near the posterior 1/3. So this is how the repair is looking at this stage. Then when I started to proceed, can you go for the next slide, please? So when I examined the notch, I could make out a hidden ramp lesion here. So this is a reason why the meniscus tissue was lying anteriorly. So at this stage, I couldn't do a posteromedial approach and use a suture lasso to repair the lamp. So this particular stage, the fiber stitch was very handy. So I used a fiber stitch here to repair the ramp lesion as well. So when you are using an implant-based all-inside, the hold of the small implant against the posterior capsule is very, very flimsy. It can actually pull out. But when you are using your fiber stitch, the suture material holds very nicely against the posterior capsule. And in this case, we were able to achieve a good reduction of the ramp lesion and good repair. So this was a missed lesion, which was a lesson for us to even look for it, even in case of an obvious bucket-handle tear, so that these lesions can be addressed. So this is how the meniscus was looking at the end of both an extensive bucket-handle repair and a ramp lesion repair. Next slide, please. So ramp lesions or the hidden lesions that can be present up to 16% of ACL tears. One has to go to the posteromedial compartment, look for it in each case. And this is a schematic of how it's being repaired with a posteromedial portal lasso, and you can use PDS or fiber sutures in this case. And on the next slide, you can see an arthroscopic repair of the ramp lesion. Once again, a suture lasso is being used to pass through the capsular tissue and also into the meniscal suture. So these lesions are being recognized much more commonly because we are first and foremost we are aware about these lesions, and we are also aware that these lesions can contribute to biomechanical stability after your ACL repair. So with this, I conclude my presentation of my case. Meniscus repairs are successful, and in case of complex tears, we have to decide each case by its own merit, and one has to have multiple techniques at hand to address challenges that can occur during the surgery. All instruments and implants should be available, and the patient should always be counseled that these neglected tears are a bit difficult to repair. One may end up excising them, or even after a good repair, there is a good chance, 20 to 30% chance, that may fail later. They may need a second procedure to do a meniscectomy later. With this, I conclude my talk. Over to you, Mark.
Sure, thanks, Joseph. Yeah, I think it really highlights something important. How do you make sure now that you don't miss those ramp lesions?
Yeah, Mark, interesting. Is actually one of the questions that's coming through here. You know, that would you view the posterior compartment of every ACL reconstruction that you're doing?
Dr. Shetty, do you want to answer that for us?
Yes, Mark, I think the literature from Sondri Cote, etc., has been very clear for many years. And in my practice, I see an incidence as high as 25-30% of these lesions, especially when chronic. So I go in the posterior medial pouch in each and every case. I place a spinal needle there. I probe that tissue. If there's any doubt, I don't even hesitate taking a portal and doing a formal evaluation of that area. And most importantly, I think in the pre-op assessment, not in the bucket handle tear, obviously, but in the pre-op assessment, the ramp lesion patients always have a no endpoint kind of a Lachman. They are very soft. So that gives us a fair idea that you need to be more careful in your evaluation in this posterior medial corner.
Yeah, too true. I mean, I think he clearly states it out that unless you, one, visualize, two, actually probe, and that doesn't always mean that you require a portal there. You could just use a spinal needle, as you pointed out. Occasionally, one will need to put in a portal if you're suspicious of it. Those chronic ones might just need a bit of a dusting with your torpedo shaver to reveal it underneath. And then, as you said, invariably needs somebody to do that from below. Vish, any more questions coming in from there?
Yeah, just before I do so, I think Mark had his hand up there. Mark Frame, Dr. Mark Frame.
Yeah.
So again, that kind of access into the back of the knee, that's where using something like the nanoscope as an accessory tool is really, really useful. And if you want to visualize that without making a formal posterior portal, you can make a much smaller hole and be able to pop in the nanoscope and have a look in more detail rather than doing that with a bigger scope. So that's a really useful extra that's now available to us.
Yeah, true. Could be a great opportunity.
So the next question is actually for Dr. Mark Frame. All suture, all inside implant. Why? What was the driving factor for you?
I think, minimizing any hard implants in patients is probably a good thing. I think that, as mentioned before by one of the other chaps, is that there's a very different feel to how that grips the soft tissue. We've all had it where you've got that flimsy capsular tissue, and unless you're quite deep in with the PEEK implant, it can often pull out. Whereas with the fiber stitch, that gathering and the knot that it produces, I think is in certain tissue, certainly it feels like it grips better. But again, it's just minimizing the amount of implant and plastic that you're putting in patients, and volume-wise, it's much smaller. So that makes sense to me.
One last question here, chaps, and I guess we can kind of go around the table and then look to close the meeting, Dr. Mark Ferguson. So a young, active patient below the age of 25, partial radial tear, white zone, repair or resect?
I'll that first.
Who we want to start with? Yeah.
I think it's a common theme with all meniscal stuff, is that, again, if you've addressed it with the patient and the patient understands the potential risks of reoperation and failure of these, I think the meniscus is such an important structure within their knee, and the function of the meniscus is so important that I can't see a huge amount to be lost in an attempt at reconstructing that meniscus. Clearly, if you've got a situation that you've got ragged edges, a complex tear that's really not repairable, or is going to give you a very abnormal functioning meniscus, then that option of just resecting it is always there. But in somebody who's young, who has healing potential, I was looking in the preparation of this. It was interesting that there's a couple of case reports of spontaneous radial tears that actually healed themselves on second look. So these were patients that hadn't even had them repaired, and they'd had a second look arthroscopy further down the line, and their body had just glued these back together. So I think somebody who's in their 20s, giving them any opportunity to try and give them a functional meniscus for the rest of their life, in my view, is worth it, given the low morbidity of the tools and things that we have now.
Dr. Joseph?
Yeah, I agree with Dr. Mark Frame. But if the tear is involving just 1/3, probably I may go for a trimming, 1/3 of the width of the meniscus. If it is going to the 2/3, probably I will consider repairing. But once again, I will tell the options to the patients that it may work or it may not work. And actually, the more posterior lesions, radial tears located in the posterior aspect of lateral meniscus, they tend to heal very nicely. So I'd be much more willing to repair lesions in those areas. This would be my take. But if somebody who can understand, who can afford a second surgery, probably I will go for a partial meniscectomy and balancing if the tear is in the white zone.
Dr. Shetty?
I think wide zone, clearly wide zone tear, there is no reason for me to take a chance with repair, because if it doesn't heal, it becomes a potential stress riser for it to further increase. So if I'm 100% sure that it's in the wide zone, then I would do a nice balancing, nice meniscectomy to make sure there is no more stress riser effect. But yes, I would be making it 100% sure that it's in the wide zone. My threshold for repair is slightly low if it's on the lateral side, for obvious reasons. We all know that the lateral meniscus contributes more to protection of cartilage on the compartment. My threshold is low when it is posterior to the popliteus, because the healing potential is very high. My threshold will be low in the presence of an ACL reconstruction. But in general, if it's a purely wide zone tear, just trimming and call it a day.
Ready?
Yeah, Dr. Mark, I completely agree to Dr. Nagraj, and very well said. I think it's the wide zone. I think one need to relook where the tear is going, confirm it's a partial, it's only conformed to the wide zone, and then probably trim the tear in the wide zone. I think that suffices the.
Yeah, I think as Mr. Frame said, observation that how well these things heal, and we don't really appreciate often, especially in the young patients, what the body can do. And I had the opportunity to actually go and have a relook of one of our rugby players a couple of months after he did an ACL and a radial tear. And even the white zone had healed, surprisingly enough. I found no little residual edge. So very, very little tolerance to not repair these things. I think if you see them, that propagation is a possibility, as you said, and even we know that partial meniscectomies can alter your biomechanics. So if we can do it, we've got some great simple techniques that have been shown this evening for those tears. You've got nothing to lose. I think we've got to, unfortunately, stop there unless there's another urgent question, Vish.
No, that's great, Mark. I think, from this end, we wish to thank all the faculty once again for all their sincere efforts, and yourself as well, Mark, for helping us pull it together. Thank you very much indeed.
No, thank you. Thank you to everybody there. Thanks, Evan. Have a great Sunday. Enjoy the rest.
Thank you, everybody. Take care. Stay safe.
Thanks very much.
Thanks, gentlemen. Thank you once again.